Welcome. I am Reverend Kerri Parker. I'm the Executive Director of the Wisconsin Council of Churches. And on behalf of my colleagues on staff and partners across the state, I'm glad to welcome you to this opportunity to learn more about how to keep your communities healthy. The Wisconsin Council of Churches is a network of churches and faith-based organizations committed to working together across differences. We focus on holy imagination and helping each other make courageous choices that lead toward peace with justice, the vitality of the church, and the well-being of our neighbors. The council connects 2,000 congregations from 21 Christian traditions in Wisconsin. Our co-sponsor today is the Wisconsin Early Childhood Association. Believing that quality early childcare and education is fundamental to creating a better world, the Wisconsin Early Childhood Association, otherwise known as WECA, works to advance positive change for children by focusing on the professionals who provide childcare for well over 70% of Wisconsin's children. They strengthen the capacities of childcare professionals through professional development, advocacy, communications, and research. I'm pleased to welcome my colleague from WECA, Chanel Clark, who's team coordinator for the Wisconsin Early Education Shared Services Network. She's made some time in a very busy day in order to be here with us. Chanel will introduce our speaker.
Thank you. I'm happy to introduce Dr. Ben Weston. He is an associate professor in the Department of Emergency Medicine at the Medical College of Wisconsin. He serves as Chief Health Policy Advisor for Milwaukee County. In addition, Dr. Weston is the Director of Medical Services for the Milwaukee County Office of Emergency Management, overseeing medical services for the 15 fire departments throughout the county. He has been featured in MSNBC, CNN, BBC, Good Morning America, NBC Nightly News, and in Politico and the New York Times. He practices clinically in the emergency department at Freighter Hospital, a level 1 trauma center. He has research interests in pre-hospital care, resuscitation, health equity, and public health surveillance. Welcome, Dr. Ben Weston.
Thank you. I'm glad to be here.
Excellent. Well, let's get right in. We don't have a lot of time today. We're glad you're here. Could you start off by telling us a bit about the monkeypox outbreak and where do we currently stand nationally and in Wisconsin?
Sure. So historically, we have seen very little monkeypox. So it's not a new disease. It was first discovered in 1958 in research monkeys, and the first human case was in 1970. Now, up until this point, monkeypox has typically been seen in Central and Western Africa. There have been outbreaks in other areas. Actually, in 2003, Wisconsin got some notoriety for having an outbreak of monkeypox, but they've all been small. They've all been contained. So this is unlike anything we've seen with monkeypox before, and that's likely due to some mutations in the virus that is changing the dynamics of how it spreads. But right now, where we're at is globally, there's about 60,000 cases. In the United States, you have about 23,000 cases. And in Wisconsin, we have 64 cases. The good news in Wisconsin is that we have not seen much of a rise in cases over almost a month at this point, or at least several weeks, I should say. There's not been a single new case in the last 2 weeks in Milwaukee County. I think there's been one new case in Wisconsin in the last 2 weeks. So we certainly seem to be leveling off with our cases. And we're seeing similar trends in the US as well as globally right now.
That's exciting. I'm glad to hear that it's leveling off and we have minimal cases and leveling off. Still being concerned, what are the concerns that we need to be thinking about with monkeypox for our state?
Well, certainly we need to be concerned about how it's spreading, how to limit that spread. And then for certain high-risk populations, there is a vaccine available. It's been a vaccine that's been around for a long time. The way that vaccine is given has been changed a little bit recently to allow it to be given to more people because that vaccine is in shortage globally, but particularly in the United States. So the main concerns are making sure that we understand the spread for healthcare providers, making sure we understand how to recognize the disease, and for individuals, knowing if you're in a population that should go out and get the vaccine.
Very helpful. For my particular role, I'm in childcare and Reverend Dr. Kerri is in churches. What are the things that we should be looking into to keep our population safe and protected?
Well, it's important to understand the populations that have been generally at risk for monkeypox. So maybe taking a step back, we've heard this conversation of, is monkeypox a sexually transmitted infection or not? So you'll hear different opinions on this. One of the facts is that it is in most cases transmitted through sexual contact. There's other diseases that are like that too. And that's just because of the close contact that goes on, but it can be transmitted not through sexual contact as well. So it's not strictly a sexually transmitted infection. Now, when we look at the demographics of who's been infected primarily up to this point, so in Wisconsin, for example, 98% of cases have been among men. And most of those cases are among men who have sex with men. And it's due to the close contact and the relatively close-knit community that encompasses. And so for folks who are outside of that community, for folks who have not, and I should back up, men who have sex with men with multiple partners. And that's an important caveat. So for people who don't have multiple sex partners, for people who don't have intimate close contact with multiple different people, at this point, with the transmission that we're seeing, the dynamics of the virus that we're seeing, you have a pretty low likelihood of getting infected with monkeypox.
Very helpful to know. Knowing that the population that I particularly serve is at pretty minimal risk, are there other things that I should be looking out for to keep the population I serve safe?
Well, from a monkeypox perspective, I think it's important for people to know, again, what the presentation is like and whether they qualify for vaccine. Now, of course, outside of monkeypox, there's lots of other things going on. COVID is still going on. So anybody, no matter who you are or where you are, you're far more likely to get COVID than you are to get monkeypox. You're also far more likely to get really sick with COVID or to die with COVID, even still, than you are with monkeypox. So I think there's obviously different things to be concerned of, different things to be aware of. But luckily, a lot of the prevention methods kind of overlap. They are spread in different ways. Monkeypox is much more likely to be spread through skin-to-skin contact and really prolonged skin-to-skin contact. That's why we see it more in intimate sort of settings and relationships. COVID is far more likely to be spread through respiratory droplets or aerosols. So breathing the same air as somebody is how you're going to spread COVID, whereas having close physical contact with somebody is how you're going to spread monkeypox. But a lot of the same principles apply. And a lot of that honestly comes down to basic infection control sort of principles. So washing your hands, having hand sanitizer available, for whether for monkeypox or COVID, or honestly more so for everything else that you can get sick with, wiping down surfaces, having good ventilation. Those sort of things can make a world of difference. And of course, being up to date on all your vaccines that you're eligible for is your best method of protection overall.
So it sounds like, Dr. Weston, you're saying to us that a child care center that is really good with its cleaning protocols, all of the things that providers know how to do and they should be keeping up with anyway, should be keeping their children and their providers safe then.
I would say so. So at this point with monkeypox, we've seen it contained to that pretty specific population of men who have sex with men with multiple partners. We haven't seen much spread in childcare environments. Now, it's important to note that even though monkeypox has been around since 1958, this outbreak is different, and we're still learning about it. Just like we were learning about COVID 2.5 years ago, and we're still learning about COVID now. In a similar way, we're still learning about monkeypox and what the dynamics are. Even though cases are leveling now, that's likely due in part to vaccine, but also in part due to a change of behavior in high-risk populations. And so as that behavior changes again, we might see differing dynamics of the disease. A big part of how likely you are to contract a disease has to do with the prevalence in the community. So think about COVID. We all have been thinking about COVID for a long time, so it's maybe a bit more familiar. So In Milwaukee County, for example, right now, we're just on the edge of getting to low levels. Okay, we're in medium, but we're getting close to low. So if you go out to the grocery store, you have whatever percent chance of encountering somebody in the line, in the aisle, whatever, at the counter who has COVID, and you're going to be sharing their air, and you might get COVID, right? Now, when the level of disease in the community is low, there's not that many people around who have COVID. And so you can go to the grocery store and there might be one other person in that grocery store who has COVID. They may or may not be infectious at that moment. You may or may not be around them for a long enough period and breathing the same air as they are to get infected. But then you go to a high level. So think about what we had earlier this summer, or certainly think back to in January when Omicron was just starting. At that point, you go to the grocery store, there's probably 20, 30, 40 people in that grocery store who have COVID. And so as you're walking around, you're a lot more likely to breathe in that virus and to have them transmit it to you. And so a lot of this depends on not just the infectivity of the virus, but how prevalent it is in the community. And with 64 cases that we know of, obviously there's more, but 64 that we know of in Wisconsin, you're just not that likely to run into somebody who has monkeypox. And to not just run into them, it's not about sharing air, remember? It's more about having that close skin-to-skin contact for a prolonged period. And the chances of having that are just pretty low right now. So I think whether we're talking about a religious setting, whether we're talking about a childcare setting, I think your likelihood of contracting monkeypox is quite low.
Sure. So I think this kind of leans into the more general public health question for me then. How should we be communicating to our constituents about these increasing number of public health concerns that come our way? How can we as organizations that reach really a large number of people in our population be responsible partners with public health?
Yeah, it's a great question. I think that question applies to religious organizations, to childcare organizations, but really to any organization that has, as you do, influence over many people, and that ability to communicate with many people in a trusted sort of manner. And so I think there's a few things that are helpful when you're trying to communicate health issues to people. I think one is to stick to facts. There is a lot of misinformation out there, misinformation about monkeypox, misinformation about COVID, misinformation about, take your pick. We're in a era of misinformation. And so I think having carefully sourced, carefully researched information is critical. And there are good resources. There's the Wisconsin DHS, there's the CDC. These are there's the World Health Organization. These are the sort of organizations that have, lifelong experts that have been working on this and have no vested interest other than your health. And so using those organizations and taking advantage of those organizations to craft your messaging. And so messaging around the importance of vaccination, messaging around the importance of masks for certain people in certain settings. And again, depending on disease burden, when there's very low levels of COVID in the community, masks may not be as important. When there's high levels in the community, masks are much more important. And talking about that, talking about what high quality masks are, talking about who's actually at risk for monkeypox, talking about what sort of presentation monkeypox has, things like that. But I think sticking to facts from reliable sources and advocating for those sources and advocating for the guidance from those sources is going to be the best path forward.
We have a question that's come in through the chat. As we've experienced with COVID-19, how we talk about disease and who it affects can be just as impactful on care and on risk as the disease itself. And this person wants to know how we can speak honestly about monkeypox without fueling stigmas about LGBTQ folks.
Yeah, it's a great question. And it is admittedly a fine line to walk. And so I think it comes back to talking about the facts, but also try not to stigmatize a group. So for example, you think back to the beginning of HIV. And so I don't know if probably somebody on this call knows, but the original term for HIV wasn't HIV, it wasn't AIDS, it was GRID, and GRID stood for gay-related immune deficiency. And when you have a term like that, you're going to stigmatize a group. You're going to make people think, number one, they don't want to be around that group because they think that that's where they're going to catch the disease. And number two, and just as critically, they think that they can't get it because they're not part of that group. And so I think there's a lot of lessons to be learned from the HIV epidemic, pandemic, as well as many other diseases, that we want to stick to the facts and inform people of their level of risk, but also inform people of how infectious disease transmission works. It doesn't care whether, what your gender is. It doesn't care what your race is. It doesn't care what your sexual orientation is. That virus will infect you if it can. The purpose of a virus is to infect and to replicate, and it could care less. And so I think talking about that while everybody is at risk, there are higher risk groups. And that's just because of the demographics of the disease that we're seeing.
One of the pieces of information that I became aware of is that the population of men having sex with men became aware of the spread of monkeypox fairly quickly because they were accustomed to looking for unusual lesions on themselves because of the awareness they had from previous pandemics, from HIV and that experience. And so, I think the practice of being aware is really important. I don't know if there's something you can speak to about that.
No, I think it's an important point. So communities of, especially white communities of men who have sex with men, tend to be very closely connected with healthcare. And a lot of that is because of the HIV epidemic and because of other demographic factors that play into that. And so certainly clinics that are more geared toward LGBTQ communities had heightened awareness of this disease, just like they have heightened awareness of many other diseases, whether they're sexually transmitted infections or sexual associated infections, like this seems to be. Now, what's interesting though is, and this is why I refer to it as men who have sex with men instead of gay, bisexual, transgender, because many men who have sex with men don't consider themselves in any of those categories. And research shows us that that's particularly the case among populations of color. Some people consider themselves straight and say, I don't have any other sexual orientation, but they are men who have sex with men. And so that's where I think, and you'll hear different opinions on this, but my opinion is that putting any labels out there along with men who have sex with men is harmful to getting the message out, because many people don't identify with the labels you're going to choose. They may identify with a different label or not identify with any of those labels. So they're not, for this conversation, I don't think they're necessarily helpful.
That's really important to know. Thank you, Dr. Weston. As people's awareness becomes flooded with more and more concerns, right? We've had so much alarm coming at us. How can we raise people's concern and attention to an appropriate level without going overboard? Yes, we want to pay attention to fact, but we also can't say, yes, this and this and this and all 25 things need to be on your radar screen right now. Right.
No, I think it's a great point. And we've seen that, whether it's with COVID, whether it's with monkeypox, whether it's with polio now, that's certainly in the news. We've seen that there's this sort of flavor of the day of what is the infectious disease that we're talking about now. And the challenge is that humans, all of us, are not good at measuring risk. We think of, we get on an airplane and we may worry about the risk of that, and we don't even think about it as we get in our car, which is infinitely higher risk than getting on an airplane, right? But our brains don't work like that. And so I think a lot of people are very concerned about monkeypox because we've seen the pictures and it scars and it causes these lesions. And it's, you know, it scares me. And I've run into many people like that where they say, oh, I'm not worried at all about COVID, but monkeypox, boy, I'm really worried about that. And whereas that individual demographically has pretty close to a 0% chance of getting monkeypox. Whereas it's much, much higher for COVID or fill in the blank of whatever other disease is out there. So I think it's hard. And I think it's hard, especially because when you watch the news, whether it's local news, national news, it jumps around to what is the topic at hand, what's the interesting, dramatic story right now, as opposed to what's the one that we should continue to be concerned about. And without delving deeply into all the data and all the science, it's hard to know which thing you should be concerned about. So I think that gets back to the idea of, you know, to some extent, bread and butter disease prevention. And that is, you know, back to hand washing, back to ventilation, back to surface cleaning, and things like that. That'll prevent a huge majority of spread of illness. Now, the other thing I think you can do is talk to your local health department, and hopefully your local health department is willing to engage with you and help you figure out what the best prevention measures are. Because those folks, again, they have one interest, and that interest is the health of their community. They're not, you know, I know here we get back to misinformation. No health departments are making money off of vaccines. No health departments are making money off of testing or you know, any of that stuff. It's not, in fact, most are losing money because they're not well funded. And there's very little national funding anymore, if any, for any of that. So their interest is the health of the public, and that's what they're committed to. So if you can engage your public health departments, they'll be a major ally in helping you to sort out what's the most important thing for you to do to protect the folks that visit you and congregate with you, or the kids that you care for.
So what I'm hearing is that basic cleanliness, having masks available to folks who might need them, having good ventilation is not alarmist. It's appropriate public health behavior. That being in touch with your public health department is being a good neighbor and helpful to the task. And that at this point in time, none of our constituents should be in a position to be alarmed about monkeypox, but they should be aware, particularly if we are working with populations of men who have sex with men.
I think that's accurate. Yeah. Now it has been extended to other populations. Initially, it was mostly men who have sex with men. Now it gets into a few other things. People in these categories generally know who they are, but it's, you know, research or clinical labs that deal with specimens, or people who are actively being investigated by public health. But most of those folks are going to know who they are, and they've been contacted to say that. So I agree with everything you said. The one thing I might add in there is think of and consider being a site, working with your public health department to be a site for vaccine administration. And you know, we all have COVID vaccine on our minds, but I'm talking flu vaccine. I'm talking catching up with childhood vaccines. You know, we hear about the polio outbreak that's happening in different places. If you're vaccinated for polio, you don't need to worry much about that polio outbreak going on, right? And most of us were vaccinated as kids, but some folks weren't. And when you were a little kid, you probably didn't have much of a choice in whether you were vaccinated for polio. But as an adult, you do. And so you can go back and do your catch-up vaccinations. And if you haven't, you know, if you're not up to date, if you haven't received all your COVID boosters, you can go ahead and do that. And if you don't get your annual flu shot, we're due for a bad flu season because people have been masking and people have been preventing flu, and that won't be happening as much this winter. So we may see a bad flu season. So I think that's another opportunity to work with public health. And I think by having it, the people, especially for the churches and the religious organizations, I mean, you know better than the folks that come there have a lot of trust in you and a lot of faith, religious, but also non-religious faith in you and in what you recommend and what you tell them. So if you and your congregation and the leaders of your congregation are believers in the vaccine, I hope you are, then then, extend that to your parishioners. And nobody's forcing, we talk a lot about forcing, nobody's forcing the vaccine on anybody, but having it be available and breaking down those barriers where somebody doesn't have to go online, find a vaccine site, schedule an appointment, drive across town, whatever it is. But on Sunday, when they come to church, at the end of church, there's a vaccine available, and they can get it administered right there if they want, and get themselves and their families, and by extension, their community and your church more protected.
Sure. I know the Wisconsin, state of Wisconsin Department of Health Services partners with us on a COVID vaccination outreach project. And we're really grateful to have been able to work with them throughout the pandemic so far. And I really do hope that churches take advantage of that opportunity, because we can still help with outreach and scheduling clinics and things like that. And just to be clear, we did not cue Dr. Weston to say this. It worked out that way. But it really does matter to make things available and accessible to people, because the fewer steps people have to take, the easier it is to get past any hurdles or personal barriers that might have them say, oh, well, maybe later.
Right. Yeah, I mean, I think people are busy. And a lot of folks have, especially in lower income brackets, they have multiple jobs, and they have kids, and they may lack transportation, and it might, church might be the one time a week when they get their whole family together, and they go out and they don't have to work, and they, have their kids with them, and they're able to access something like that. And it may be hard at other times, and so giving that opportunity can be critical. It may be the one opportunity they have to easily get vaccinated. Otherwise, it's a production. And if somebody, I often think of the folks who have multiple family members or multiple kids, multiple jobs, no transportation, and so they have to get on a bus or somehow get across town to get to that vaccination site and either drag their kids with them or try to afford childcare. Are they going to do that? Maybe, but are they going to do that when they hear all this misinformation about the vaccine, and about all the it causes miscarriage and it causes death and all these things that are not at all true? I don't know that they're going to make that effort. But if they hear from people they trust about the facts of the vaccine, if they have it available right there, they're a lot more likely to get it.
Dr. Weston, I need to say thank you, because you have been a very grounding, calming voice in a sphere that has been all about escalating anxiety. So I'm really grateful that you've been able to be with us today. Is there anything that we haven't touched on that you want to make sure we hear?
I think we've touched on a lot. I think there's folks from all over the state. I was looking at the chat and where people are from. So there's really people from all over the state. And one of the things we've seen with COVID, one of the things we've seen with monkeypox, and are seeing more and more as data emerges. And honestly, what we've been seeing for decades, whether it's heart disease, cancer, take your pick, is there are more vulnerable communities are hit first, and our more vulnerable communities are hit harder. And in some areas, the vulnerable communities look like populations of color. In other areas, vulnerable communities are low income or are more rural. And so it depends. In each of your communities, you know who your vulnerable folks are. So I think in particular, reaching out to those folks, seeing how they're doing, and also vulnerability may be people who live alone and perhaps are older. So reaching out to those folks, seeing how they're doing. This has been a hard time for everybody, especially people who don't have that social structure to help them get through something like this. We talk about, social distancing. I try to say physical distancing, but a lot of people say social distancing. And that's not what we want to do. We don't want to cut off our social ties with other people. And so sometimes it's just that outreach, that phone call, that touch base that can make all the difference for somebody who's been pretty isolated over the last 2.5 years, or who's been affected more than others by these diseases over the last 2.5 years and more. So certainly think about your vulnerable communities and reach out to the vulnerable folks that you serve, whether they're kids or parishioners.
So really that spirit of community care that we need to rebuild.
Absolutely.
Cool. Again, thank you so much, Dr. Weston. your voice is apparently all over the airwaves, and you have made room for us here in Wisconsin. And on behalf of those of us who know how important public health is, thank you for dedicating your career to that kind of practice.
Well, this was my pleasure. I enjoyed being here, and thanks for having me.
Good. Again, for those of you who are watching real time, if you want to make this Q&A available to folks in your circle, you can watch our YouTube for the recording to pop up, or watch your inbox for notice that the recording is available. We also usually put the link up on our Facebook page as soon as it's available. So, Dr. Weston, everybody who's listening today, have a great day.
Take care, everyone. Bye-bye.
Take care.